Good morning. Good morning, good afternoon, or good evening, everyone, from wherever you are joining us today. And welcome to Silent Live's fourth and last webinar in our series, focusing on behavior change communication. A special welcome back to those who attended our previous webinar and those joining us for the first time. We're delighted you could log in today. And if you would like to hear what we discussed in webinar 1 to 3, a link to the slides and the recording is available in resources on our website, silentlive.org. In this webinar series, we examine the BCC process from the program manager's point of view. We emphasize experiential knowledge combined with research analysis and identify tools and tips to help the program manager manage the BCC process. In our last webinar, webinar 3, titled BCC Strategy and Roll-Out, The Devil is in the Detail, after reviewing the BCC process cycle step 2 and 3, desk review and client research, we examined the key requirements for developing a BCC strategy and touched upon some essentials such as the exchange in BCC. We also examined in detail the creative design process, step 4 of the BCC process cycle, underpinned by real-life BCC strategy examples. Pre-testing the creative is a key requirement to ensure the creative content meets audience needs, which we discussed in step 5 of the BCC process cycle. And finally, in our last webinar, we looked at provider or staff training requirements for operationalizing the BCC strategy in step 6. And we also touched upon the essentials of an implementation plan in step 7. My name is Jana Maniuk, and I am a social marketing specialist at Silent Live, and I'm delighted to be moderating today's webinar. Over the next 45 minutes, my colleague Dr. Eva Monterosa will present webinar 4, entitled Monitoring the Process, Does It Work? And now just a little introduction to Silent Live. We are a humanitarian think tank guided by the vision of a world free from malnutrition. We focus linking research to implementation to support positive nutrition outcomes. Our work involves guiding original nutrition research, disseminating its findings, and facilitating dialogue to bring about positive change in this regard. Before we begin, just a little housekeeping. If you are not oriented with Zoom, you will find a toolbar at the bottom of the Zoom window. You may have to hover your cursor along the lower part of the window for it to appear. Here in the lower left-hand corner, you can manage your audio settings. The chat box can be found in the middle. If you have any technical difficulties or general questions during the presentation, please type them into your Zoom chat box and we will do our best to find a solution. You will also find the Zoom Q&A in the lower toolbar. At any time, please submit your questions for the Q&A session following the presentation through Zoom Q&A, not in the Zoom chat. I will pose as many of your questions as possible as the time allows. We're also active on social media and encourage you to engage with us through our Twitter hashtag #SalWebinar, which will appear in the chat box. And finally, a PDF of the slides and recording of the webinar will be available on the Silent Live website shortly after today's webinar. And now, without further ado, it's a pleasure to introduce today's presenter, Dr. Eva Monterosa. Eva is a senior scientific manager at Silent Live, and in this role leads the implementation science area, managing a broad portfolio that includes food supplements and market delivery models, behavior change communication models for complementary feeding, women's nutrition, and nutrition and WASH. Eva also offers strategic advice to partners in academia and UN agencies on design and implementation of nutrition programs and assists WFP in behavior change communication. And now I will hand over to Eva for the presentation.
Thank you, Jana. Just letting my screen load. And trying to get away from presenter view. Go. There we go. Well, thank you, Yana, and welcome back to those who have been with us since webinar 1. Glad to have you again for webinar 4, our final webinar, where we will look explicitly at the monitoring and evaluation for BCC. Again, thanks to our communication and design team, Nola and Annie, and many thanks to Yana for her valuable inputs in today's webinar. So let's get started. We will cover 6 topics in the next 50 minutes. So we have a lot of ground to cover. First, we will review what we did in webinar 3. Then we'll move into the topic of monitoring and evaluation by distinguishing between monitoring and evaluation activities. Then we'll examine the program theory. And then we'll move into BCC objectives and the monitoring framework. And then we'll talk about what's included in a monitoring plan. That's the 5th part of the agenda. And then lastly, we'll tie everything together and review the 8 steps that we have gone through in this webinar series. So let's review webinar 3. Okay, we covered 4 steps in this webinar, but they were all focused on the process of intervention design and implementation. And the important takeaways from Jana's presentations were the following. When designing the intervention, you need to focus on the exchange, particularly on decreasing the cost and highlighting the short-term gains of doing the behavior. We discussed also the operational mix and how quite often we jump right into the promotion and forget about the behavior itself, the place where people will be doing the behavior, and where we will reach our audience, as well as reducing the costs of doing the behavior while emphasizing its benefits. We also discussed a bit about the content strategy, which is much more than just key messages. Then we discussed that a creative brief is needed when you're outsourcing the content development to a service provider, such as an advertising agency, as well as the need for pre-testing your content before launching into the BCC intervention. We discussed the need for training staff, not only on the content itself, but also on the communication skills to effectively deliver the intervention. And then finally, we dove into the implementation plan and talked about the need for phasing and the costing of each activity. So that's everything we covered in the last webinar. So now we are in step 8. In monitor and evaluate, we've reached the end of the BCC process. So we've come full circle. And as we've said many times, this cycle is iterative, and we're often working on multiple fronts. And in the next section, you'll see how most of the monitoring elements have come together in steps 4, 6, and 7. All right. The objectives of today's webinar is to help the program manager construct their own theories of change and results framework. The program manager should also be able to set the SMART objectives and know what to include in a BCC monitoring plan. And by the end of this webinar, we hope that the program manager will have understood the utility of outcome monitoring for tracking results. Let's get started on monitoring and evaluation then for BCC. I'd like to begin this section by making a distinction between monitoring and evaluation, in part because I see many program managers rushing to evaluation because it's the only way to generate valid data. That's what a lot of people say. I hope that by the end of the presentation that I will have convinced you on how to better use monitoring to give you evidence for whether or not your BCC intervention is achieving results. I will speak briefly about evaluations because that's a lot to cover in this 50-minute presentation. And I think monitoring is a powerful tool that gives immediate results to the program manager. So evaluations are no doubt important and they have their place, and they're especially useful for decision making, but it's also the domain expertise of evaluation experts. So I think it's something we'll cover in a future webinar perhaps, but not necessarily today in any depth. All right, let's begin this conversation by distinguishing between monitoring and evaluation. Monitoring is a continuing function that provides the management and the main stakeholders with early indications of progress or lack thereof in the achievement of results. Monitoring then is a management function. It is led and executed by the management team. So the program manager is directly responsible for monitoring. Evaluation, on the other hand, is a selective exercise that attempts to systematically and objectively assess the progress and achievement towards an outcome or an impact. Evaluation is an evidence function, and it's often led by an independent party not involved in the entity being evaluated. Monitoring allows a program manager to answer the following question. Does one have a quality program that is functioning as intended? It is in answering this question with a resounding, yes, I do have a quality program that is functioning as intended, that one can and should initiate an evaluation. Okay, so having good monitoring or good monitoring of your program is a prerequisite for an evaluation. So I've created this slide drawing on the best practices from the UNDP Monitoring and Evaluation Handbook, and we've cited this reference in the resource section of the presentation. I want to flag a few things on this slide. On row A, as you can see, before you start monitoring, you're going to need a plausible program theory. And I'll show you how to construct a theory today. So we'll do that today. On row B, the purpose of monitoring is to help the program manager do his or her job better. So my advice is to take quite seriously the monitoring. And today we'll show you how to set up the monitoring plan and how to use it, how to use your day-to-day functions to help you monitor the BCC intervention. And row E is that we really can't monitor everything. I wish we could, but we can't. So you have to be strategic about what you monitor. And it's important to decide with the brain trust what's important for accountability purposes. Okay, so what are the key elements for successful BCC program monitoring and evaluation? Well, the first one is to have a theory of change. The second one is to set BCC SMART objectives and having a monitoring framework. And the third one is to have your approach and methods as laid out in a plan. So we'll go through these in more detail in the subsequent slides. Let's start with the theory of change. So every program needs a theory of change because a theory of change explicitly lays out how the program is supposed to change behavior or to have a health impact. If a theory of change can't be articulated, be very suspicious. It usually means that the program exists on paper, but not in practice. Or perhaps worse than that, someone is implementing a program that is not focused on changing anything. So we're wasting donor money, or worse, we're wasting tax dollars if we're not explicit about our change theory. Crafting a theory of change is relatively easy if you have followed the 8-step BCC process. You didn't know this, but we've been working on a change theory all along, and now it's time to pull the pieces together. So here are 2 generic questions that apply to any nutrition program and can help you understand how the intervention is expected to change behavior. Answers to these questions are available upon completion, essentially, of step 4. And it's important to articulate your theory of change quite early on in the design process and be open to challenging it as you develop the content strategy and the implementation plan. So let's have a look at these 2 questions in more detail. Okay, I'm sharing with you the change process or conceptual model at this point of one of the projects we worked on last year in Rajasthan, India, where the aim was to improve nutrient intakes among pregnant and lactating women. I've talked about the Eat More, Eat Better project in webinar 2 when I discussed the client research and generating insights. So when we had completed our client research, we had developed this conceptual model that you see on the screen. And these were the factors involved in food choices during pregnancy and lactation among low-income women. Some of our key findings were that women had very little autonomy when it came to what foods to consume. The mother-in-law owned and operated the food domain at home, and this was especially true in multifamily homes in rural areas. With regards to access, husbands were responsible for the food purchases. And among multiple family homes, the meals were shared. So any efforts to get women to eat more at meal times meant that everyone had to eat more. And this represented a high financial cost to the family as a whole. From a knowledge point of view, the women were especially keen on learning what was happening to the baby as it was growing and how food could support their baby's growth. So the factors in green, what you see here in green font, were the levers we wanted to pull as part of the BCC communication intervention. Factors in the red font were the major constraints that we had to design around. And the factors in black font are those factors that were outside of our control. Some of these are immutable to a communication strategy, so there's not much we can do there. And others are at the individual variability level that is difficult to address through public health strategies. So how do we go from this complex food choice model to a theory of change? I'll show you, and it's actually not that complicated. We first start by looking at the exchange value. So from the client research that you've just would have completed at the end of step 3, you've generated insights that have focused on the exchange. And we talked about the exchange in the last webinar. And the exchange can help us in answering the question, what is the change process and is it plausible? And here were the 3 exchange values that we had for our Eat More, Eat Better project. The exchange value for the husbands was that a small investment in food and care today results in a lower risk of complication and expensive medical bills. So that's a short-term gain for them. And then a healthy baby in the long term. The exchange value that we designed for the wives, for the pregnant and lactating women, was that a small exchange in food consumption today meant tangible effects on the child development. And then the third exchange value was for the mother-in-law, where we were asking and encouraging her that the mother-in-law, by encouraging her son to be a good father and a good husband, resulted in ensuring a good delivery and a strong grandson being born. So all of these were important outcomes that if you were to do an impact evaluation, for example, you might want to decide to measure these elements as outcomes. So that's the exchange value. Another way of creating your theory of change is to use the operation mix, which we also talked about in webinar 4, where we outlined the different components and the functions of the intervention. Now, according to behavior change experts, the source of behavior is a combination of capability, opportunity, and motivation. So on this slide, I've also added those elements to this table, so you can see how the function will influence one of these sources of behavior. So let's take a look at this table. One of our first components of our intervention for the Eat More, Eat Better project was a media campaign, right? And the function of this campaign is persuasion and aspiration. So that we could motivate the target audience. And in this case, the target audience were the husbands, the mother-in-laws, and the wives. The second component that we had for our intervention was a welcome package that they were to receive at the first antenatal care visit. And the function of this welcome package is also persuasion and aspiration. Again, we want to motivate the target audience, and this one was dedicated particularly to the husbands and the wives. The other thing we wanted to do through the welcome package was to improve opportunity and capability. And then the last part, or the third component of our intervention, were home visits by the frontline workers. And these visits served 3 functions. One was to offer engaging education on foods and how they influence child development. The second one was to support snacking behaviors and reminding the mothers to keep refilling her treat bag that came as part of the welcome package. And then the third thing we wanted to do, the other way that we were supporting, was giving support to the mother-in-law to encourage her son to buy foods on this grocery list that was also part of the welcome package. So those are the 3 different intervention components, and they each serve similar or different functions. And you lay that out as part of a way of understanding, helping you to understand and unpack your theory of change. So now to actually doing the theory of change. Before I get to this, I just want to say that when I show you what's on this slide, I would recommend you doing this activity with your brain trust. In fact, you can prepare for them the document with the exchange, with the operational mix that we just saw, and then you have your brain trust create their own theories. It really is quite fascinating to see the various views that stakeholders might have of a particular intervention. And it also helps in generating a common understanding of what can be achieved through the intervention. Okay, so in a theory of change, you have your goal, and our goal was to increase the snacking of nutrient-dense foods. And so all the activities are leading towards that goal, right? So our change process efforts begin with the husband, right? And the aim is to convert this young husband to an active supporter for his wife's food choices. The first touch point with the husband is at the antenatal care visit. And because he enrolls his wife in a cash transfer or conditional cash transfer program that is set up in Rajasthan that pays families for hospital deliveries. So that's when we first meet the husband. Of course, he doesn't come alone. He brings his wife, and together the husband and the wife receive the welcome package that includes the following elements. They have a small SD card that they can load on their mobile phone with a couple of animated films. They get a letter from the chief minister. And there's, in addition to that, they have a shopping list that outlines which foods they should buy for their wives during this period. And of course, then the frontline or the healthcare worker that does this antenatal care visit is doing the counseling on the welcome kit. As part of the welcome kit is this specially designed treat bag, which is given to the wife as a gift, and she needs to keep this treat bag filled with healthy snacks. Now, at the home front, we have two other stakeholders that come into view. The first one is the frontline worker, who is using that home visit to discuss with the mother the nutritional benefits of the foods on her baby's development. For example, the benefit of drinking milk is that it provides calcium and protein that is necessary for bone development and muscles for the baby. Something like that. And then the last one is the mother-in-law, and who we've said is the ultimate food gatekeeper, but we're actually going to use her son to get her to support him. So instead of getting the mother-in-law to support her daughter-in-law, we're using the mother-in-law to support her son. And the son will read the letter from the chief minister and explain to her the type of support that he requires, namely to let her know when the food stock is running low and that he needs to buy more food again. So you also, in a theory of change, you want to identify your operational mix, which I've done so here in the blue boxes. And then the blue circle is this media campaign there towards the right of the screen. And note that the exchange is working throughout the change process. So I've been very explicit about articulating that exchange. And so once you have this theory of change, you can now build out a program impact pathway to detail each and every step of the process, including the assumptions. So this is just a general diagram. A program impact pathway has a lot more details. And the PIP activity is, again, it's a more advanced skill, and it's usually used a lot more in impact evaluations. But again, if you want to build a PIP, a program impact pathway, you have to begin with a solid theory of change. All right, so let's move on to the second element of monitoring and evaluation, which is setting those SMART objectives and the monitoring framework. So in this section, we essentially discuss the things that the program manager is accountable for delivering to the communities that they serve, to their program funders, be it the donors or the taxpayers. All right, so let's start first with setting objectives. So we've started the BCC process by setting the BCC goals and behavior objectives. For those of us who joined us in webinar 1, you know that's the first thing we started talking about, and it is the essence of step 1. And so we do this and we set the initial behavior objective because we have to chart a course, and the behavior objectives help us do that. So if I draw from my Eat More, Eat Better project example, when I first started the project, I set a very wide behavior objective. And my behavior objective was that women increase food intake during pregnancy. When we completed our client research, we refined the behavior objective to read, women increase food intake between meals of nutrient-dense foods that are available in the home. Right, so now we're specific about the snacking behavior, yeah, between the meals. Then in step 5, once we've designed our creative content, we can further refine our objective, and here we're being specific about what we want them to do. So in this case, our behavior objective was women snack 2 times per day and choose from 7 foods that were available in as part of their grocery shopping list, for instance. And then once we reach the monitoring and evaluation step, we can now set a SMART objective. And I'll talk about what SMART stands for in a moment. But this is now a very specific objective that can only be set once we know what the exact strategy for implementation will be. So in this case, the objective reads, at 6 months post-pregnancy enrollment, women are snacking once per day. So the SMART objectives, and SMART stands for specific, measurable, achievable, realistic, and time-bound. Now it's very important to set SMART objectives because this is the way that you keep track of whether or not your intervention is achieving its outcomes. Okay. So let's have a look at the first objective to see why it's SMART. So that objective says that at 3 months post-pregnancy enrollment, 50% of husbands express intentions for buying at least 2 of the 7 foods on the food list. It's specific because we have identified one action that we're measuring, which is intention, yeah? Intention to buy specific foods, yeah? So there's not 2 or 3 actions here. So it's specific to one thing. It's measurable because we're quantifying some change. In this case, we've quantified the 50%, and then we're saying a minimum of 2 of 7. And again, you have to be able to define success in your terms. There's no right or wrong answer here. It'll depend on how realistic and achievable these are, which now we move into those terms. So this indicator is realistic, or is it's achievable because we can measure it given our staff time and resources. So if we can't measure this outcome, then we shouldn't set it as a BCC objective. And it should be realistic and time bound. In this case, we've set a time frame of 3 months in which we would expect to see changes in intention. So again, here you have to decide, are you happy with 50% of the population expressing an intent? 60, 80, 100? That's up to you, and how the brain trust decides on what is an appropriate level of accountability, and of course the appropriate level of change that one can expect in that indicator. So it's important not to confuse SMART objectives with aspirational goals. We all aspire to 100% all the time, but we must be realistic when setting these goals, again, because we're accountable for these targets. Similarly, we set the other objectives in the same way. So objective 2 is focused on snacking, objective 3 on the quantity of foods, and objective 4 on the emotions that are created by the TV campaign. And all of these objectives support the overall program goal of increasing nutrient intakes among women. Now, we've talked a lot about BCC being embedded in a nutrition program, and as such, these BCC SMART objectives will be covered or captured in the broader monitoring and evaluation for the broader program. Okay. So some tips on setting SMART objectives. So we've talked again about the brain trust here, and for those of us who have just joined webinar 4 and haven't heard webinars 1 to 3, we've been discussing the brain trust all along, and it's this committee, your stakeholders that help guide you throughout the BCC process. And so these objectives are set with them, and this should be mutually agreed upon. And again, there's no correct number of objectives, but the more you set, the more you need to measure. So again, there's some trade-offs here. Another tip is that SMART objectives need to focus on outcomes, not on outputs. And we'll talk about the difference between those two terms in a moment. And then for each of these objectives, you will need to set the appropriate indicators. And then these indicators will be included in the overall monitoring plan for the broader program. Okay, so now we've set our objectives. Now we need a monitoring framework. The theory of change is in many ways the backbone to your monitoring framework, and your SMART objectives are the outcomes that are placed here in the monitoring framework, right? So everything we've done is now setting you up to be able to very quickly fill in a monitoring framework. Now, some institutions like to use a log frame, which is a matrix, but I prefer the results chain because it's visual, so I can see things moving in a more causal fashion. But the important thing, so whatever you choose, a matrix or the results chain, you need to have a tool that tracks inputs, activities, outputs, and outcomes. So that's non-negotiable. So pick one and use it. So a results chain lines everything up from inputs to impact. And inputs are all the resources that are available to you. The activities are the actions that you have planned. That's essentially your intervention. That's everything falls under there, under activities. And outputs are the results achieved because of the activities, so the deliverables, which the program manager is usually accountable for. Another way to differentiate between activities and outputs is to think of activities as the stimulus and outputs as the response to that stimulus. Outcomes are the changes observed because of a set of activities. So because you intervened, because you created an intervention, these are the set of outcomes that we expect to see. And outcomes are often achieved during the life cycle of the project. In BCC, outcomes are usually linked to more proximal factors, such as emotions, intentions, or beliefs that influence the longer-term behaviors. So you'll see that also being included in outcome language in BCC monitoring. And then lastly, impacts are the benefits achieved. These are either changes in behavior or a change in practice that is sustained over time. So almost like habit formation, if you will. Please note that for BCC, the impacts are not related to a health condition or a nutrition indicator, such as anemia, stunting, or wasting. So that's the wrong attribution. Impacts are always related to behaviors or practice. Okay, so let's use another example to walk you through this. Now, this is a results chain for our Eat More, Eat Better project. And let's start with the first input. So one of our intervention components was that welcome package to be given at the first antenatal care visit, right? So these are the resources. As an input, that's a resource that's available to me as part of the intervention. Now, the actual activity is the welcome package counseling. So it's not the welcome package itself, it's the actual counseling that occurs as part of the intervention. That's the behavior change component aspect of it. And so that's an opportunity for that frontline worker to share on the importance of snacking between meals and which foods should be selected. So that's part of the counseling that happens at the individual level. Now, as a result of that counseling, that's the stimulus, right? So there should be a response to that stimulus. And the response to that stimulus should be the basic level of awareness for snacking, right? The couple, having gone through the counseling, should at least know that, oh, yes, my wife needs to snack between meals, right? And then the outcome that from that intervention can be short-term or long-term changes. So some of the short-term changes would be you could measure beliefs, like expectancy beliefs and intentions, yeah? And you can have longer-term outcomes tied to behavior. So in this case, the fathers buy the foods on the food list, and the wives consume their snacks, yeah? We could do the same thing for the next components, for the media campaign. The campaign itself, what it's doing or what is being delivered, the activities of that campaign are the television, let's say television spots and the billboards, and the output for that campaign would be the exposure to those, to that campaign. And the major outcome from that is building a level of emotional triggers or emotion around the idea of the child being born a champion. Again, and this ties into other outcomes that we're interested in, such as beliefs and intentions, as well as some behaviors. So it's really hard to do a results chain without a theory of change because it gets tricky to distinguish between outputs and outcomes. And what tends to happen if you can't distinguish between outputs and outcomes, one begins to populate the output section with activity indicators. So the entire results chain actually shifts to the right, and program managers now become less accountable to behavior change and more accountable to project deliverables. So we're more concerned about doing project activities as outputs rather than the outputs that should result from those project activities, like raising awareness, like making sure that households have been exposed to that, to a media campaign, rather than running the campaign or doing the counseling. So that's one of the reasons why I advocate using a theory of change first and then going to a results framework. So here's the full results chain for the entire project. So as you can see, we have a set of outputs. All our outcomes there are in our orange boxes, and everything is helping us towards that impact of the program goal, which is improved intakes among pregnant and lactating women. Right, so in practice, what makes it into the BCC plan, it will be a function of how much time you have for M&E, how many resources you count on, what staff are available to you. So you'll have to prioritize certain outcomes over others, right? That's just choices one has to make all the time, every day. Okay, so now let's move into the actual plan. And we'll focus mostly, again, on the monitoring aspect of things, less so on the evaluation. So now, again, a monitoring plan is it can be more easily developed once you have your monitoring framework set up. So again, my advice is not to start planning without first having a framework to plan from. So on this slide, what I'm showing you here is sort of the spaces that are occupied by a monitoring function and an evaluation function. So you can think of monitoring occupying that space from inputs to outputs. And evaluation, because it's the evidence function, really focuses on those long-term benefits to health impacts. Now, program outcomes are somewhere in the middle. So some people will say those need to be evaluated only. I actually, and I think others who follow good principles of good evaluation practice, advocate for actually tracking outcomes as part of our program monitoring. And I'll show you how to do that in a moment. Okay, so if we're to stay in this space of inputs, activities, and outputs, of the results chain, we have two approaches that are available to the program manager. The first one is called implementation or process monitoring, and the second one is called process evaluation. Now, both of these approaches serve a similar purpose, namely to understand how the program is delivering the intervention. Process monitoring draws quite heavily on the implementation plan, and that was a plan we completed in step 7, and it tracks indicators throughout the project lifecycle. So again, you're looking at what the service is being delivered and how is that service being utilized. Process evaluation is much more in-depth and diagnostic, and it tends to be a one-off activity, and it's usually conducted by an external party. In fact, what often happens is that when you have less than desirable implementation monitoring results, that often triggers a process evaluation. If we move on to the outcome and impact section of the results chain, we have two other approaches that are available to the program manager. The first one is outcome monitoring, also called outcome evaluation or adequacy evaluation. There's different terms used in the literature for this. And again, this is an excellent approach to gather data and to ascertain if the intervention is delivering towards behavior change. So for this type of monitoring, you don't necessarily need a comparison group, but what you do need is baseline data or time zero data. So without a comparison group, the level of certainty in your data is lower because the changes may or may not be due to the program itself. Because you may have other programs running at the same time in your area that might be influencing these changes. So one way to mitigate this is to be sure that the outcome variables or those outcome indicators that you've selected can only be affected by your program. So if I had put one of my outcome variables as dietary diversity, well, there might be 7 programs running dietary diversity, right? So my outcome variable for the Eat More, Eat Better was snacking because I'm the only one doing a snacking intervention. So I can much better tie those outcomes to my intervention. So that's another way to get around that. In fact, if you have a good process in outcome monitoring, then it's very easy for the funder to think about an impact evaluation because nobody wants to evaluate a messy or poorly managed program. So all of these pieces have to be in place before the impact evaluation is commissioned. The impact evaluation, of course, is necessary, and it advances a lot of the evidence on behavior change, so it's important to do. And the question it answers is whether or not the benefits that have accrued in that community are because of the BCC intervention, again, above and beyond the exposures to other programs or other changes that might be happening at the community level. All right. Time for me to stop talking for a little bit and let's do a poll. Nola, can we put up our poll, please? So what type of monitoring and evaluation, should say there, have you used mostly? Have you used process monitoring, outcome monitoring, impact evaluation, or process evaluation? All right, Nola, can we see the results? Great. Most people are using process monitoring and a few others outcome monitoring. That's fantastic. And impact evaluations. So hardly anyone has done process evaluation. Very interesting. Okay. All right, so now let's get into the more details of what is in a BCC monitoring plan. So the objective of having a plan is not just to have something down on paper or to collect data for the sake of collecting data. You really want to gather data for decision making. Therefore, it is the program manager, the person that actually most benefits from having a plan in place and knowing what's happening in the BCC intervention. So your plan needs to have 3 important sections. Yeah, the first section outlines the approach, what we just talked about. All right, so we at Sight and Life, we advocate for both process and outcome monitoring, especially if we want to learn about what parts of our intervention work, for whom they work, and what were the implementation bottlenecks. So you need to select the implementation approach. That's the first section of your monitoring plan. The second section of the monitoring plan is the timeline and the roles and responsibilities, right? So the timeline, again, will depend on the resources, your organization's established monitoring routines, and whether or not you use technology for monitoring. You know, some programs have more frequent monitoring time points than others, but in our experience, the minimum frequency should be about 3 months for the data to be useful for program decision making. And again, as part of this component, you do need to have a budget for your M&E activities. You have to know what it will cost you to send someone to the field to monitor, to gather specific data. So in outcome monitoring, we're also tracking short-term outcomes, and the frequency with which you report on outcomes is something that you will have to discuss with the Brain Trust. Again, because you need baseline data for this. So this is a little bit more tricky sometimes. In the final section, you need to include what methods you're going to select for monitoring. We'll talk about those in a second, as well as those indicators. So good monitoring plans use a combination of quantitative and qualitative data. It's not just surveys. It's a combination of data points for triangulation. And an indicator is just a fancy term for something that can be quantified or counted. So an indicator has a numerator and it has a denominator. And the denominator generally in your monitoring plans are people who are actively using the programs. So it is about that population that are active users of your program or of your intervention. Okay, so let's talk a little bit about some of the means, the methods, and the tools that are available for the program manager to include in their monitoring plan. So under column 1, you'll see that there's various things that are part of the program manager's day-to-day activities that you can use. So most often, for many program managers, they have staff sending progress reports. And what you can ask is, as part of the progress reports, to include information on process monitoring indicators. And you can use your BCC implementation plan to actually track the execution of these activities. If you are tracking inventory, for example, let's say you're using a micronutrient powder as part of a BCC intervention. If you're tracking that inventory, that can give you an indication of whether or not people are showing up to retrieve the product, or coming to, or it may be an indication that the demand generation or awareness raising activities are not going well. Under column 2. There's a lot of things that the program manager does that they interact with people every day. So you sit on steering meetings, you have meetings with stakeholders one-on-one or in small groups. And so what you can do is, as part of these meetings, you have people report on the activities or output indicators. Some program managers also like to manage going out to the field. So take this opportunity to talk to staff and clients or your beneficiaries and find out what's going on from a process point of view, and get that qualitative information around your output indicators. So the important thing is for you to be strategic about what method you use, and use a combination of strategies that fall under these 3 columns. You can see surveys is only one of many things that are available to you. You have a series of methods and tools that you can combine in different ways for monitoring. Okay, a little bit more on monitoring methods. So if you have some staff time and you have more resources, you can be more intentional about your BCC activity monitoring. So in the last slide, in this slide, a lot of this stuff is things you already do as part of your day-to-day management work. Here is things that you can actually design and create specifically for BCC. So, you know, we've just listed examples. This is not an exhaustive list, but some of them we've talked about. For example, you can use event monitoring. So let's say you're doing a community level event, you can monitor at that level, or you can use real-time monitoring or use audience feedback surveys. So again, just a combination or different types of methods that are available to you. I'm not going to go into detail on this slide. I leave it here for your reference. And so once the methods have been selected, the last thing you need to set up, but actually the most critically important thing, is to identify your indicators. And again, this is not an exhaustive list, but it's just the ones we run into more frequently when we're doing BCC monitoring. So these are most common type of indicators that you'll find for behavior change communication. And as you can see on the ones on the left, that there tends to be a focus on messages and content, and then a little bit about intentions to adopt a behavior, and then you have indicators on the behavior itself. So the challenge here for indicators is that there are no standardized questions or standardized indicators for BCC. Okay, so for some in nutrition, you'll find some indicators that are standardized. Like, for instance, when we do dietary diversity, there's a dietary diversity indicator for young children. There's a dietary diversity indicator for women that have been validated. That's not the case for BCC. So what makes indicator development and creation challenging is that you actually have to do it each time for your own project. So it's important that that you have your theory of change set up, that you have a results framework, because most of those indicators will come from there. So it's not something that you can work off from a previous list. It has to be based on your theory of change. So on this slide, I have examples of some output and outcome indicators for our Eat More, Eat Better project. So on the first row, the example is engaging home visits, right? So the program manager wants to track how engaging the home visits have been by the frontline workers. And the first problem is, well, how does one define engaging? So you can go to the dictionary, and the dictionary uses words such as interesting and appealing, but you can't apply a dictionary definition for measuring engagement, just because what is interesting and what is appealing will be interpreted differently by each person. So that's not a good approach. So what do? Well, at this junction, this is where the client research that we completed in step 3 is useful once again. So when we did our client research in Rajasthan, we had learned that the type of knowledge that was interesting to pregnant and lactating women was one that talked about how food affected the development and the growth of the baby. So one way that I would measure if a visit was engaging or not would be to use a question such as, had they learned new information about how food affects their child from the frontline worker today? And you can do that. For example, you could put an SMS and send that after a scheduled home visit, right? And then you set a target for that indicator. So at least in this case, in this catchment area, we want 75% of the women responding yes to that question, right? And again, your target levels will vary. There's also no set point. There's no right answer. It's not 80%, it's not 60%. It just depends on what level, what realistic level you can set. And you can do that for other outputs and outcomes. In this case, we developed one for awareness of snacking, which we could do at exit surveys for antenatal care. And you can, do random selection of antenatal care sites and and go in and do exit surveys for a couple of hours. Same thing with emotion. So you can develop an indicator for emotion. In this case, we used Likert scale from 1 to 5, asking the mothers, do I feel that my husband is involved in my food needs? Yeah, as a way of capturing feeling cared for, feeling nurtured, feeling loved. All right, we're almost at the end, guys. Just hang in there. Okay, so in the end, so before I get off this slide here, the indicators that you select need to capture the domain that you're measuring. And importantly, these indicators and the data sources that you use, so let's say you're using an exit survey, that is the same, you have to use the exit survey throughout the project lifecycle. You can't switch to a different type of approach midway. So the indicators and the data sources need to be comparable over time. And the indicators need to be relevant to the activities being conducted. So in my example here of engaging home visits, let's say 80% of mothers answer no. This would be a huge red flag for me as program manager to go back in and say, what's going on with my frontline workers? Why aren't they delivering new information to the mothers, right? So relevant to the activities that you have planned, because it needs to flag these things for you. And again, how many outputs and outcomes you track, and how much you do at the beneficiary or client level just depends on your resources. But be sure to save a portion of the program's budget for monitoring and evaluation, right? This is hugely important, and you can't skip this part either. Because otherwise, how will you know if your BCC intervention is working? All right, and just because we can capture data in a questionnaire and because we can count it and put percents and numbers behind it does not guarantee us that the quality of the data is good. So here are some things that you need to look out for as you're collecting and interpreting the data that comes back to you. Think about self-reporting bias. People tend to over-report good behaviors and under-report bad ones. Think about attribution. How much of the outcomes are attributable to your BCC intervention, right? And some of the ways to mitigate this are on this slide, which you can read later. Seasonality. Some behaviors are easier to adopt at certain periods than others. So it's important to collect data at the same time points. If you have a very marked lean season and harvest season, you keep that in mind as you're collecting the data. And then lastly, you're not doing this for the sake of doing it, right? So at the beginning of this presentation, we said that the purpose of monitoring is to provide actionable data for program decision making. So part of this is having some sort of system in place, a mechanism in place for you to be able to reprioritize activities or do course correction. So often, again, this is done with your brain trust. So some of the ways you can reprioritize activities is, for example, if there are certain activities that are proving very popular, if you're getting positive feedback from the client or your target audience on specific intervention components, or there might be a new and emerging national or international initiatives that you might be able to capitalize on. You might need to consider course correction when the intervention is not performing against your expected results. That's why we set targets. And if it's not meeting those targets, you may need to consider a course correction. There's a negative media exposure, although we hope that if you've already done your good client research and you've done good pre-testing, that you've mitigated that risk significantly. And similar to the next one, that misconception or misinformation from the intervention in the community. Again, hopefully the good client research and pre-testing will reduce risk for that. Okay, and just to conclude a little bit on some tips for integrating your BCC M&E into the broader programming M&E evaluation. So in the case of Rajasthan, our BCC intervention would be included as part of overall antenatal care program, right? So ours is just one component of a broader program that's running. Now, some tips for doing this. Process monitoring, that is the tracking of your inputs, activities, and outputs, should be part of your ongoing management activities. So try to find ways of including that in your day-to-day and keeping track of those. The SMART objectives that we set earlier on, those need to have clear indicators, and those indicators feed into the larger M&E plan, right? Those are what we're accountable for. If we've set snacking targets, we're accountable for those targets, right? If you have monitoring staff, so if you belong to a program where there's a lot of resources and there's a dedicated staff that does monitoring either on a quarterly basis or a monthly basis, make sure that that staff is trained to collect on the BCC process. And you need to establish an efficient system for that staff to escalate issues back to you so that you can deal with those problems. Again, reserving a portion of the overall M&E budget for your BCC, and particularly for measuring those short-term outcomes to see if you're moving in the right direction. And then when program evaluations are conducted, make sure that the BCC indicators are included if appropriate. That way you'll be able to get some data without having to fund that evaluation yourself. All right, so we've reached the end of step 8, and I think I'm a little bit over time. I am. So for those of us who want to leave at this point, it's okay. I have a couple more slides that I want to talk about kind of integrating the whole process. So if you can stay on for another 5 minutes and then we go to Q&A, I'll move quickly through the next section. So these are all the things that your checklist for M&E. I'm not going to go through that because that's just what we've discussed. Let me move on to recapping the BCC 8-step process. So what have we learned across these 4 webinars and in following this process? Well, we talked initially about our 4 key principles, right? And the first principle was that this is a process that culminates in a communication strategy. So about being systematic and using a strategic mix of activities and communication. It's not only about promotion, right? And that we can start BCC if our barriers have been eliminated. So that was step 1, that the first principle, that we have a process that culminates in a communication strategy. And then the other 2 important principles were that we're audience focused and evidence based. So we focus on behaviors, we don't focus on health indicators or nutrition indicators. We make no assumptions of what the audience needs and wants. We ask them through research. And client research is not only needed for strategy design, but also for creating our monitoring indicators. At the heart of the BCC design is the exchange, and we're looking for insights that help you position the desired behavior from the perspective of your clients, not from your perspective as a program manager. And that what appears as a constraint for your BCC strategy can often be turned into opportunities. So you want to design around those constraints. And as part of the evidence-based principle, please do outcome monitoring. We are accountable for our BCC interventions. Have we had the change that we intended to have? And then the last principle was that we integrate BCC with our existing program and services, right? So it's linked to that service delivery process, and we have to be cognizant of the provider time and of the skills that are required for BCC. And we talked about that throughout these eight steps. This is iterative. It's not a linear step 1, go to step 2, step 3, step 4. As we learned today, a lot of the monitoring comes together at different steps. And this last step is just a matter of putting it together into something like a monitoring plan. But we're trying to create synergies between the steps where possible. And whenever we're stuck, we always go back to the insight and the client research that we generated, and we put the audience at the center of every problem we're trying to solve. And the last thing that I want to share with you is that there is not one person I know that does not say to me, Eva, this process takes a long time, or Eva, this process is expensive. And my reply to this statement every single time is, To spend money and rush to program development without client research is a high-risk, high-gamble activity. You do not know how many programs I've seen fail because they skipped this step. So depending on the extent of your BCC work and the problem you're trying to address, the client research doesn't need to take months to do. At Sight and Life, we're continuing to learn and refine this process, so we also want you to share your experiences with us so that we could incorporate your learnings into ours. And that the multi-stakeholder engagement secures buy-in for the BCC. So really having that brain trust guiding you throughout this process. And sort of the last learning for me has been that, and I hope you have come away from this webinar series with this, that human beings are inherently creative. We love to create, we love to design. So unleash that creative potential in you, in your team, and use more cost-effective resources. You don't have to hire really expensive companies to do this work for you. There's a lot of people out there who can do elements of this work, such as freelance journalists, if you need writing to be done. Writers, there's professional writers out there that could do writing and copy editing, graphic designers for content development, and you can think about industrial designers who do a lot of human-centered design work. They can also support you in this process. And 30-second pitch for Sight and Life, but if you do want the advice of experts, Sight and Life does offer BCC services. And here's a list of some of the services we offer, from program design to formative research to, or client research if you want something more specific. We also do trainings either as workshop format or a course. So this webinar is an example of such trainings that we can do. And then if you need any strategic advice, we're also happy to offer that, both on demand generation or BCC related activities. And of course, you can get in touch with us with info@sightandlife.org. So with that, Jana, I end the webinar, and really thanks to all. I'm sorry I went over, and I hope we can have an engaging Q&A for another 10-15 minutes for those who can stay.
Thank you very much, Eva, for this great presentation. It's now time to hear from our audience, and I see some questions that have been posted. I'm going to start here with the first one. An anonymous attendee is asking, I need to reach 15,000 people in 18 months with a BCI. I assume that he or she means behavior change information or communication.
Intervention, BCI, behavior change.
Behavior change intervention. What activity should I use as the basic indicator for the counting the reach? I have group trainings through an existing program, media campaign, and medical outreaches as part of the activities. So I assume the question is about, what indicator is best to count reach when you have many people in a short time period?
Right, many people, but also many different activities. So you have a different, for each activity, you would have to count reach. Again, and for 15,000 people, so if you're not just reaching 100, a lot of that comes in through service provision. So there has to be a way for you to be able to count those people already. Otherwise, you have to set those systems in. And so either your service provider has to count how many people they see related to your intervention, your BCI intervention. You have to set that up in order to be able to count numbers.
Okay, thanks for that answer. And then we have another question here, which is, what if you don't have the budget for a BCC-specific impact evaluation?
So that's a good question. Most people actually don't have a budget for an impact evaluation. Again, so outcome monitoring is the solution to that. So trying to keep track of those outcomes, is particularly the short-term outcomes, and embed those into an M&E plan if you can. So a broader plan, broader program management plan would be the solution.
Thank you for that answer, Eva. Another question here is, If you aim at changing actual behaviors through your BCC, but your program cycle does not allow enough time to see actual changes in behavior, which indicators can you use to still demonstrate valuable change?
Yeah, that's a good question. So, of course, behavior takes a longer time, but there's more proximal indicators that you can use. So we talked about beliefs. So you can measure beliefs, you can measure awareness. Yeah, so those are usually the ones. Intentions for behavior are more proximal, shorter term.
Okay, thank you for that answer. And then another question here is, who would do BCC specific evaluations if we were to look for outsourcing this activity?
Good question. I'd have to get back to them on that. I know of a few agencies that do such work. I would actually, this so this BCC evaluation wouldn't be different than, let's say, a health impact evaluation, right? So it's the same processes and approaches are used. That would be sort of my simple answer to that question. But I think there are a few people that have specialized in behavior change evaluations, but I don't know those off the top of my head right now.
Okay. And I think we have just time for one last question, and I'm going to pick this one. Why do you need to spend time on the theory of change and cannot just move on to the monitoring framework?
Good question, Jana. Well, as I said in the presentation, that sometimes it's hard for us to distinguish what is it that we're trying to do. What we struggle to make explicit the change process, and it becomes too activity based. So by doing the theory of change, it forces us to think about what are the exchange values that we're trying to promote, what are our different intervention components, and what are their functions. And that converts something that is implicit or held in different sheets of paper into the theory of change, and allows us to articulate how is it that we're going to change that behavior. And then we can more easily talk about our intervention rather than just saying, oh, we ran a media campaign or we ran home visits. No, we had this intervention that was really focused on motivating and persuading key target audiences for improving and supporting mothers to make healthier choices. Like it gives you a different way to talk about the intervention.
Great. Thank you, Eva, for this, and thank you for your presentation. Unfortunately, we have run out of time for any more questions today. So I'd like to thank all of you for your active participation, and we hope that you found this presentation, but also our entire webinar series informative and thought-provoking. Please do visit our website to stay up to date on further events, and also to check out the recordings of all the 4 webinars. Please remember that we're also active on social media and welcome your thoughts, comments, and engagement through our Twitter and LinkedIn page. Once you leave today's webinar, you will receive a very brief survey on the presentation, and we would really appreciate if you would take a moment to provide your feedback so we can improve future activities. You'll also receive a follow-up email with a link, of course, to today's webinar recording and a URL to the PDF of the slides. And on behalf of Sign in Live, once again, I'd like to thank you for joining us today, and have a great rest of the day, everybody.
Thank you. Thanks, Jana. Bye-bye.